Good afternoon. I'm Shubi Tandon, a program coordinator at the Institute of Healthcare Improvement, and it's my pleasure to welcome you to today's virtual learning hour, Workplace Violence, Protecting Healthcare Workers. Before we begin, I have some quick housekeeping remarks. The session is being recorded and all audience lines will be in listen-only mode during this program. The handouts for today's presentation were made available to all attendees in advance of the virtual learning hour and will be shared again after we conclude. There will be a question and answer session later in the program. We collected questions ahead of time from participants, but you're also welcome to submit your questions throughout the program. To submit a question, simply type your question in the chat box and click the send button. If you don't see the chat box, click the speech bubble at the bottom of your screen. The box will then appear on the right-hand side. If the slides appear to have frozen on your console after we begin today, please try refreshing your browser by clicking the Control and R keys on your keyboard or the F5 button. If you have any additional tech issues during the virtual learning hour, please let us know through the chat box and we'll work to address them. This session has been accredited to offer 1 hour of continuing education credit for physicians, nurses, pharmacists, healthcare executives, and CPPS recertification. All event faculty and staff have disclosed in accordance with requirements. To receive continuing education credit, registrants must register on the IHI website, attend all of today's virtual learning hour, and then complete a post-event online evaluation. Additional details will be shared at the end of today's event and then will be emailed to all attendees. It's important to note that only registrants attending the live virtual hour are eligible for credit. These are our learning objectives for this session. I'll now be handing the moderator, Patricia McGaffigan, a VP at IHI, to begin today's virtual learning hour.
Thank you, Shubi, and welcome everyone to Patient Safety Awareness Week 2021. This week was actually begun by a patient and family advocate after the death of their son due to preventable healthcare harm. And this week is intended to elevate awareness and education around patient safety across our communities, to recognize the progress that we've made, and also to provide a booster shot to renew our will and keep striving for our shared vision to eliminate preventable healthcare harm to patients and those who care for them. Each year, IHI offers this virtual learning hour to focus on a topic that is broadly relevant, and our topic for 2021 is workplace violence. We have an incredibly important topic today, and we also have a fabulous lineup of faculty. Shubi, let's move on for a quick overview of who's speaking with us today. And we will also refer you to the materials on our website for additional information. The next slide, please. Dr. Amar Shah, Jeff Brady. We'll start out with Dr. Brady. He's the director of the Center for Quality and Safety at the Agency for Healthcare Research and Quality, and also co-chairs our National Steering Committee for Patient Safety. Dr. Brady will be providing some commentary on workplace violence, and then we'll open it up to each of our faculty, who will speak for about 8 to 10 minutes each before we rejoin in a panel discussion where Dr. Brady will moderate some questions, including those that you might submit over the chat box yourselves. Second, we have Dr. Amar Shah. If you would move the slide, thank you so much, Shubi. Dr. Shah is a consultant forensic psychiatrist and chief quality officer at East London NHS Foundation.
What I recommend is calling in.
He's also joined by Dr. Stephen Muthing. You can advance that slide, Shubi, for us. Dr. Muthing is the Chief Quality Officer and the co-director of the James Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. And we are also joined by Mary Beth Kingston, who's been serving in the role of Chief Nurse Officer for Advocate Aurora Health. We welcome all of our faculty, and Dr. Brady, you as our moderator for today. And now I'd like to hand things over to you to kick off the afternoon. Thank you.
Well, thank you very much, Patricia. Just a quick sound check. Can folks hear me okay? Great, thank you. Well, again, thank you, Patricia. And on behalf of the entire healthcare safety community, I'd like to thank you and the Institute for Healthcare Improvement for all that you do to advance the cause of patient safety and healthcare worker safety. We have an impressive panel who will, as you've heard, will walk us through a very challenging topic today. Workplace violence has become a critical problem in healthcare. Here you see two definitions to help ground our session. And as I read the definitions, it's alarming to me how dramatic and harmful these events can be. I think they represent a sort of social emergency that demands our attention. They're troubling in any workplace, and they are particularly distressing in institutions whose missions are to heal and provide care. I've come to understand workplace violence as both a symptom of underlying problems and a cause of others. More generally, the effect of healthcare worker safety on patient safety draws our program's attention to this important topic. Next slide, please. These connections are outlined in the National Action Plan for Patient Safety that we released in the fall. Working with the Institute for Healthcare Improvement and other influential organizations throughout healthcare, we came together to examine the current state of patient safety in order to understand the slow progress with patient safety improvement. Our recommendations for accelerating efforts to prevent harm were organized in 4 foundational areas. While safety is threatened by multiple hazards such as medication events, falls, diagnostic errors, infections, and many others, these 4 prerequisites emerged as the cornerstones on which safer care is built. The safety of the healthcare workforce is one of these 4 areas, and the relationship between these 2 safeties, patient safety and workforce safety, is complex, but the connection is obvious when you consider the contradiction of needing healthcare workers to devote more attention to patient safety at a time when they themselves may be distracted by their own health and safety. And workplace violence in healthcare is a tip of the iceberg that highlights this dilemma. So today, let's listen for opportunities to be very intentional in taking action, keeping in mind the interdependencies across the 4 foundational areas that the panelists will be addressing. So with that, I'd like to turn things over to Dr. Amar Shah, who will share some of his experience with the National Health Service in the UK. Dr. Shah.
Thank you very much, Jeff, for that introduction. I'm going to share the story of our work on one of our biggest workplace violence issues at East London NHS Foundation Trust. And it's a story that lasts many years, dating back to 2012. I'm just going to pause for a moment because I've lost access to the slides, Sarah. So I wonder whether you could bring them back on screen.
Doctor, I am currently still seeing them, but I'll take the presenter role back so that I can move the slides forward for you instead. And let's see if the slides come back up that way.
Thanks, Sarah.
No worries. Can you see them now?
Yeah, that's great. So the story I wanted to share was our work to reduce physical violence across an organization in England that provides mental health, behavioral health, primary care, community health services to a population of about 1.8 million people. And we have about 6,500 staff spread across quite a wide geography. So with that as the context, let me just try to describe a little bit about the problem we were faced with several years ago. Next slide, please, Sarah. So when you look across the English NHS and look at violence in healthcare settings, what you can see here is the number of incidents each year hasn't really changed, despite a number of efforts from successive governments to issue policy, to bring into force laws that prevent and take punitive action on people who are violent within the NHS. That's had very little effect on the actual levels of violence. Next slide, Sarah. And off that, there are actually 3 times as many incidents of those occur in mental health settings, behavioral health settings, as in other healthcare settings. When we looked at our own data, you can see there the red bar on the left are all of our incidents of physical violence at our organization as a category compared to all of our other safety incidents that are reported. So you can see it's by far and away the #1 safety incident that we have and face in our organization. And if we ask our staff, they would also tell us that it's the biggest issue for them when they're working in inpatient settings. Next slide, Sarah. In fact, when we started to have these conversations, what we realized was there were much deeper impacts of physical violence than we had previously probably understood. So here are some of the things that we heard from our patients and from our staff as we started to focus in a little bit on this as an issue for us strategically as an organization that we wanted to try to tackle. And we recognize the impact on our staff, not just in terms of safety at work, but the subsequent effects on dreading coming into work, the effects on the team, the effects on patients and their recovery and how long they're spending on a ward and whether they really feel safe enough to focus on their own recovery in a ward where they feel unsafe. Next slide, Sarah. So when we began to apply quality improvement as an organization, now nearly 10 years ago now, this was one of the first topics that we tackled before we really knew even how to use quality improvement very well. This is a picture of the first ward that started to tackle the topic of violence. Globe Ward was our busiest ward, highest number of admissions, highest levels of violence. It was really a bit of a war zone if you walked onto Globe Ward. You really felt unsafe walking into the ward. But they decided to test out using quality improvement because they'd never had any experience of it before. And when they asked their staff what was the issue they really wanted to solve, the staff and patients both said violence on the ward is the one thing we really want to solve. So they looked at the literature. There wasn't a lot of evidence base, and that may be a theme here with looking at workplace violence. There aren't sometimes evidence-based interventions, but they looked at what there was in the literature. There were some case studies, and they came up with their own ideas of what might make a difference, and they developed their theory of change as a driver diagram, as you can see here. Next slide, Sarah. And they started to apply the method of testing and learning, and they realized that there was a number of interventions when they tried them that seemed to help them predict when violence would occur and take preventative action. And they managed to reduce violence down considerably on this one ward, which has now been sustained for many years. And what we wanted to do after this was take the learning from one single ward and say, could we now adopt this learning in other settings across the trust? This is one ward of 50, and physical violence is not just an issue on Globe Ward. So having seen the amazing results they've achieved, what could we do to take this work to scale? And that is the beginning of a 5-year journey, really, of learning how to apply, adapt, learning from one ward to other wards. Next slide, Sarah. Here's the safety culture bundle, which we've now published, which you can read up in more detail. But essentially, there were 2 change ideas they tested around increasing the openness and transparency on the ward about this issue, using safety crosses as one change idea, and talking about it in community meetings as the second idea. And then increasing their ability to predict and respond. So bringing in a dynamic risk assessment and then using safety huddles, which previously they hadn't really tried before. So those 4 interventions together seem to lead to this effect that they were seeing. Next slide, Sarah. So we started to work on adapting this bundle in other settings beyond Globe Ward, and started with the 6 wards in Tower Hamlets. Next slide, Sarah. And we learned over the course of the next year, with a bit of adaptation, how we could take the learning from one ward to those 6 wards, and saw a reduction in physical violence across all of those 6 wards for about 50%. Next slide, Sarah. And then we went further to other units in 2 neighbouring boroughs of Newham and Hackney, where again we were able to. It took a year to really work with the teams, help them understand the interventions that had worked, create their own theory of change, test them in their environment, measuring in a standard way, and adapting based on their own context. Next slide, Sarah. And you can see here the results from Newham and Hackney, both of whom have seen, big sustained reduction in physical violence. Next slide, Sarah. And we then took that to our forensic settings and to Bedfordshire and Luton, and eventually to every inpatient unit and ward across the organisation. And so we've seen now across the whole organisation about a 30% reduction in rates of physical violence across the organisation. And on the lower half of this slide, what you see is, as well as looking at our own data, you can see as a red dot, we have seen a reduction in our numbers and rates compared to other mental health providers across the country. So it wasn't just that levels of violence reduced everywhere. We saw reductions internally, but equally when compared to other mental health providers, we've seen a big change over that 5-year period. Next slide, Sarah. So what are my key learnings? Well, having tackled our number 1 workplace safety issue, the big learning has been that this work really only begins when we bring people together to share their experiences, really understand everyone's perspectives on it and the impact of this issue, and start the difficult conversations. And this was hitherto too big an issue for us to even talk about. People knew that it had an impact, but there were no conversations about it, and we certainly didn't have a way to work through it that we then learned that quality improvement provides for us. Next slide, Sarah. We also needed to involve everybody in it. And certainly when you're going from one ward to 50 wards, you need to make every ward feel like they own this and it becomes their work. And so finding creative ways for people to really own this was important. And here's artwork from Hackney. And, you know, they were partway through the scale up, but they really felt like they wanted to bring their creative lens on this and involve their patients in depicting in artwork what it felt like to be on a ward that was unsafe, and then depict what it felt like when there were less incidents of violence. So in finding ways to involve everybody and make people feel like it's their own work is really important. Next slide, Sarah. And then we've got found ways to keep this work fun. You know, when it took us 5 years to go from 1 ward to 50 wards, and maybe we could have done that faster. But certainly keeping people's energy up and enthusiasm for this work is really critical over that long period. So we've found ways to bring an element of fun into this and make it feel local. And each unit's had a chance to really make this feel like something they've developed and created themselves. Next slide, please. So we've started by bringing people together to design the theory of change themselves. And at the beginning, this involved patients, it involved carers, it involved police, it involved staff at all levels of the system, and really involving people to come up with their own theories of what would make a difference, and have that represented in a shared theory of change is absolutely important. Next slide, please. Coming up with a single structure for oversight has been really important, with executive level sponsorship, a structured program of learning sessions that bring teams together to learn from each other, just like you would in a really well-designed improvement collaborative. Next slide, please. And a measurement system that helps people learn. So, you know, some standard outcome measures that everyone can see transparently, so they can see where something's happening that they want to learn from. They can see their own data, not just the outcomes, but the processes, the new things that they're trying as well, to see if they make a difference. Next slide, please. And now we've moved into the territory of quality control. We've moved from testing and learning what might work to really understanding that there are these 4 interventions that, when done in a reliable, routine way, seem to help us predict and prevent violence. We're now building quality control systems where there's really clear standard work. Who needs to do what on a daily, weekly basis to make sure these new ways of working are embedded in the team? How can we keep an eye on the performance of the new system using visual management? And how can we regroup around this on a regular basis so that we can keep reflecting on how well these new processes are functioning in our teams, whether we need to try anything differently, whether there's an issue that we need to come together and think about problem solving. Next slide, please. So in summary, I would say, you know, here's one example of a workplace issue related to safety of our staff that we thought was too big to solve. Quality improvement's given us a mechanism to systematically and in a structured way work our way through it, but absolutely critically involving people deeply in that process of change. You know, having a way for staff and patients to talk about the issue, own it, and then apply a solution orientation to thinking what could they do differently to start making small inroads into this, what sometimes feels like a very big issue at the start, and over a period of years to see the impact this has had across a large healthcare system. Thanks very much.
Well, thanks, Amar. This is Steve Muthing, and I have the honor of following up that great discussion. Before I jump in, I just want to thank everybody at IHI, the whole team, for putting on today's event, and thank Patricia and Jeff for being our panel moderators. And thanks, Amar and Mary Beth, who will follow me. It's an honor being on the panel with both of you. I really just want to share 2 points today. There's so much we could talk about with workplace violence, and I know all of you could. So I really just want to focus in on 2 items. And one is from my home organization, Cincinnati Children's, and one is actually based on learning we've received from our safety learning network for all the children's hospitals across the United States and Canada. Next slide. So let me just introduce myself. You've got my biography, but I think more importantly, I just want to let you know I'm a husband, I'm a dad, I'm a grandpa. I actually started my career as a country pediatrician. That's what I did for the first 13 years. I initially moved to a place where there was no pediatrician in 3 counties. And I learned there safety was personal because I knew everybody. I eventually became an improver, moving to Cincinnati Children's. But I have to say, nowadays I spend most of my time sharing and learning together with all of you. And I actually spend a lot of time learning how to learn together better because I think it's important. And this topic of workplace violence is indicative of that. If we all need to learn together. So I want to thank all of you, both for being on today, but for all the work you do to continuously improve workplace violence and all of employee safety. So my first story I mentioned is from Cincinnati Children's. Let me give you some background on that. Next slide, please. So Cincinnati Children's, I don't really want to get into all the numbers. I want to tell you we've been on a journey over the last 25 years since we adopted that vision. You can see at the lower part of the slide there, to be the leader in improving child health. And over that time, we've moved from being what I would describe as a regional hub, an excellent children's hospital for our region, to really an international hub. We see kids from all over the United States, really all over the world. And very interestingly, we now have employees from almost 100 countries at Cincinnati Children's. We're growing. We're soon to actually be a little over 800 beds this year, just for a children's hospital. And we have a large research facility. Mostly, I just want you to know it's a complex place. But one of the things that you might find surprising as a children's hospital, we have a huge behavioral mental health program, actually a facility with over 120 beds. And that's where my first story goes when we think about workplace violence. It's those kids and those staff that we're trying to serve there. So, and just another piece of background about what's been going on at Cincinnati Children's. Next slide. About 2 years ago, as part of our ongoing journey of safety, which really goes back 20 years, we knew for various reasons we needed to go deeper into our culture journey. And we actually created an entire new approach to psychological safety because our front line was clearly telling us our psychological safety at Cincinnati Children's was not what we thought it might be, and definitely not what we needed it to be. And we created a whole program around this, and it's focused on the head, the heart, and the hands, knowing when to speak up, feeling safe to speak up, and having leaders create that environment where it is safe to speak up, listening up, and listening with grace and gratitude when others speak up. And thankfully at Cincinnati Children's, we actually finished initially training all of our leaders, and then they trained all of their teams. We finished it up just over a year ago, right before the pandemic set in. And COVID has become the best place for us to test this out. We've used this relentlessly every day, both for the kids' safety and our safety. So that's the background, but let me go deeper now in the story. Next slide. Did we skip one? Maybe not. If no, well, one disappeared, no worries. We got to be adaptive. But let me give you a little bit more on this story and where it came from. I mentioned that we have a 120 bed facility just for mental health. Unusual for a children's hospital, but 2 things happened coming out of that facility. 2 things told us we had a problem. One was our data. And as part of our safety journey, we have a very transparent, open approach to our data. And our data was telling us, because of events similar to what Omar showed, we had a problem. But more importantly, through our Safer Together work, our psychological safety work, our front line was speaking up and telling us, we have a big problem. And what they told us was things along the lines of, this work is my life's calling. This is exactly what I want to do, but I can't keep doing this. It's not safe. People are getting hurt and we're afraid of getting hurt every day. The staff did exactly what Safer Together training had asked them to do, which was to speak up, and leadership listened up. And what we did is we took the same approach as if it was a serious safety event with severe harm or death in a patient safety world. And we applied our standard organizational approach, which starts with our chair of the board and the CEO declaring this as a major event. One of our senior executives is assigned this event. We go through a root cause analysis or failure modes effect analysis, and it routinely reports through our safety oversight board, which is chaired by our CEO. And eventually everyone in the organization is made aware of both the analysis, the work to be done, and the results. And in this particular time, they realized this was not going to be something that we could do superficially. We had to go deep. And what they found is, in many things, but the three I just wanted to call out was our mental health, behavioral health work needed to create a deeper system around situation awareness, predicting where the harm was going to happen rather than just reacting to when the harm happened. Similar to the way we approached in patient safety clinical deterioration. They knew we needed a care model design. The concept that a small percentage of the kids were resulting in a lot of the harm, we needed to figure out what those children needed to help them differently than what the other kids needed. And then finally, realizing that some of these children had no other place to turn, we needed to start working with partners within our community, helping to find answers for these kids so they didn't continuously end up in places that caused them to escalate. Let me share the second story. Next slide. This one, oh, there's a picture of our behavioral health center. Things just got out of whack there. No worries. Next slide. This story comes from our safety learning network for the 140 children's hospitals. It's called Solutions for Patient Safety. If you want to learn more, because I can't tell you everything about it, I'd encourage you to go to solutionsforpatientsafety.org. But this is a network of children's hospitals, began with just 8 in Ohio, but now it's over 140 across the United States and Canada. And what we've all learned how to do is to learn together. We share all of our data, all of our successes, all of our failures, and we have one common goal and with a deep belief that none of us can achieve this goal by ourselves. It requires all of us. Next slide. Solutions for Patient Safety, or SPS, has that one goal: to work together to eliminate serious harm across all children's hospital, not just for the kids, but for the staff who work there. And we fundamentally believe the only way we're going to get there is to all teach, all learn together. And we do this at the front line. We do this at the clinical leader level, but we also do it all the way up to the board level and the CEO level. Our CEOs get together and teach each other what they're doing, what works, what seems not to work. Our boards do it also. Just this month, we've had separate sessions for both boards of trustees members and CEOs, where they literally share with each other rather than listening from an expert. And I wanted to share you what they've all agreed on seems to be working for those organizations that are having the fastest improvement on workforce safety. Next slide. What they've shown by studying each other and sharing these practices is these three things seem to be in common with those organizations within SPS that are making that most fast-paced progress. Three things. One is they've found ways to make patient and workforce safety foundational, whether it was as a strategic goal or as a value for the organization, or maybe as a foundational risk in their risk management system. But either way, these leaders broke through and have made this work foundational. And you can see it when they talk. They never stop talking about it. They're always talking about it. They know their data and they know it deeply. The second thing is they've begun to see safety as an investment rather than a cost. everyone knows it takes money to solve some of these intransigent problems. But if you see it as a cost, you're comparing it to other things and trying to reduce expenses. And no, you can't throw just money at it right and left. But when you think of it as an investment and the staff being an incredibly important success factor for your organization, you start to think of, well, of course I would invest in that. Why wouldn't I invest in that rather than comparing it to other costs in your system? And finally, what they've done is they've created a transparent learning system. Amar spoke about this for East London. This is what the children's hospitals are seeing also. You need to share this data. It should not be kept simply within small groups or just within senior management. Everyone should know what's causing harm, and everyone should be together working on finding the system successes. So it's those three things that the children's hospitals together have been learning. And those are the things I wanted to share, both the work we've done at Cincinnati Children's and across all of Solutions for Patient Safety. Next slide. And I want to thank you for your time and your commitment to safety. And now I want to turn it over to Mary Beth.
Okay. Thank you, Steve. Thank you very much, NMR. Just interesting to hear the different stories and how people are approaching this very significant problem. I'm going to talk a little bit about the CNO lens, but the organization where I'm the chief nurse is a 26 hospital system, primarily acute care hospitals, but we do have a freestanding children's hospital and behavioral health, and many, many clinics and home care. So a full integrated healthcare system. And we just merged, Aurora Healthcare merged with Advocate. It's not just, I guess, 3 years ago, but my journey started at Aurora Healthcare. And just a quick story before I jump in, that I was, and I'm going to say we've been on this journey since about 2014. I had pulled together, as I typically do, meetings with chief nurses of our different sites. And I was relating a particularly difficult, very violent situation that had happened in one of our hospitals involving a nurse who was severely injured and really was going to be leaving the profession. And all of a sudden, one chief nursing officer turned around and said to me, well, someone was just strangled in my organization 2 weeks ago. And someone else said, oh, we had someone hit. And I was just all of a sudden had all of these incidents, and we did not have a system to be looking at all these incidents or this problem as a whole. And so that was just a huge wake up call and began our journey. So first I want to talk a little bit about nursing specifically, and then I'll get into some specific about lessons learned. Next slide, please. So just a few quick statistics. 1 in 4 nurses report being assaulted. And I mean, that sounds staggering to me, but then you see the next stat that up to 80% of workplace violence incidents affecting nurses are not reported. And that's, I mean, we've learned that over the years as we talk to people. You've heard it's part of my job, I don't want to get, it wasn't their fault, all of those things, but really impacts our ability to craft strategies and target them to the right places if we don't have that accurate reporting. And then 13% of missed work days can be attributed to workplace violence, a very important statistic as you build in your organizations the business case for investing, as Steve said, in safety and not looking at it as a cost. Next slide, please. So, we all think about violence, physical violence, and that is obviously extremely upsetting and can have major consequences. But there are this group of behaviors that also fall into the violence category. Certainly we know intimidation and threats from others, but also what we would call BUHD behaviors. And that's bullying, which has received a lot of attention in the news lately. And you can see the definition there. Harassment, which can also occur, and that's really looking at violating an individual's dignity or creating an intimidating or hostile, degrading environment. Discrimination, which involves unjust or prejudicial treatment, and undermining. And this is one that we do see, unfortunately, in healthcare often, behavior that undermines professional competence. So you have a newer nurse that comes on and you have, just eye rolling when they're, as they're suggesting something or asking a question. I would contend that these behaviors contribute, I don't want to say more than, because it depends on the physical violence piece, but these behaviors really contribute to turnover in all of healthcare, but particularly in the nursing profession. I work with a nurse who works with patients who are victims of violence. She was a detective before she came into this role. And she said she was surprised by the degree of these behaviors in healthcare. She said in the police force, we had each other's back. And that we've taken her on the road to talk about this, which has been really helpful. Next slide, please. So the impact of all of this in nursing, but in all of healthcare, is well documented. Depending on the injury, you can have, could be minor, could be long-term, it could result in death, lost individual productivity, decreased wages. You can see the effects here. Excuse me, but the stress and psychological effects that were mentioned earlier, I think have a huge impact. I worked with a nurse who, excuse me, I should have brought my water. I worked with a nurse who had a shoulder injury, was out of work, and came back and worked in the ICU because she could no longer, or she was afraid really to work in the acute care setting. And she called me one day and said, I don't know if you're aware of it, but the person that hurt me has been readmitted. And I did not receive a phone call about that. And I said, I appreciate that. I said, but you won't be coming in contact, and now you have to trust that we are identifying this. And she said, oh no, I have to warn everyone. She 4 to 5 months after this event continued to just need a ton of support, understandably so. But the impact covers so many areas, not just the physical injury and even being out of work, and really impacts again that time of coming back to work. Next slide, please. So how did we approach it? Obviously, from my initial description, we did not have a systems approach. And I think the most important thing, and Jeff mentioned this, and as did Steve and others, is linking this with patient safety. I had the wonderful opportunity to co-chair one of those work teams, which was workforce safety for the National Action Plan. And it really, in my mind, was one of the first plans that has come out that has truly said you cannot have patient safety without workforce safety. We know this, and yet we've done a much better job of moving patient safety forward, particularly with our boards. Steve mentioned executive commitment. This has got to come from the board as well. And I will tell you, it's only been in the last two to 3 years that we've had regular reports on workforce safety, including workplace violence, to our boards in my organization. It requires that commitment. But as you can see here, in a number of studies, only 50% of hospital and healthcare system board respondents in one survey had knowledge of risk to the workforce. My own sister, when I was talking to her about this, said, I had no idea that this occurred in healthcare. In a Press Ganey survey, none listed workforce safety in their proposed metrics to support high quality patient care. So we have a lot of work to do in getting that governance, that workplace violence into the discussions with our governance teams. Next slide, please. So for implementation, and I'm going to, due to time, not going through these quickly, but I want to tell you that one very important resource with the National Action Plan is that there is an implementation guide. And you can see some of the recommendations here. There's also resources listed there, which are really helpful, as well as an assessment guide where you can benchmark where you're at as an organization, where your progress is. And so I would recommend highly that if this is an area you're working on, to tap into all the pieces of the National Action Plan. Next slide, please. So in terms of our journey, a few things that I would mention. One is we didn't have the organizing structure. And so we've built that now. We have our overriding structure is linked with patient safety, but also with all the other workforce safety, safe patient handling, slips, trips, falls, all of those things, psychological well-being and health. because we believe that the safety principles guiding this are the same. And that's been an important organizing structure. For workforce safety specifically, we obviously have a system group, but we have work teams at every site that tie into that so that we're getting that best practice, that sharing of information out. The link with patient safety, in my mind, cannot be overstated. Some of the lessons we've learned, some of the lessons I've learned going through this are that, initially when we first started, just the awareness, just talking about it, I would have people say to me, oh, this is happening. This is good news. They were, uncomfortable about the fact that people were not talking about it. So we had a major awareness and communication campaign. Not enough, but good to get started. Resources, the board engagement, but also resources. We absolutely have to have dollars put to this. If we don't, we will not be successful. And that, again, starts with your board commitment and understanding the investment in patient safety. Simplified reporting. We tried so many different things. We had people calling in. We had all different things. Didn't work. We had to make it very simple. And we are not there yet with our reporting, but we have increased our reporting dramatically, which, again, we don't want to see more events, but I think these events are happening anyway. And that, to me, is a key area of focus. How do you increase reporting to drive your strategy? Engagement of others, we've mentioned that. I would say the partnership in acute care with our security and safety personnel is the most important. The system approach to this, and not having a knee-jerk reaction when one thing happens, understanding how that impacts something else. And I'm also doing some work with the American Hospital Association, and I wanted to mention that as another resource. Their focus this year in their violence work is workforce safety, and they're partnering with the Global Hospital Organization, as well as IAHSS, which is the International Association of Security Professionals. So lots of work going on in this area, lots of lessons learned. And I just thank you for the opportunity to share a little bit of our journey with you today. And now I'll hand it over to Jeff for questions.
Oh, that was really impressive. I think, as we hoped. Thank you to all of you for that really interesting overview. I think an overarching takeaway for me is that as challenging as this problem is, and as harmful as it is to people that we all care about, that we work with, there's definitely cause for hope and encouragement in terms of how to tackle it. So we'd like to get into the question and answer period. I think just a bit on logistics. We are going to use the chat. If participants would like to chat in a question, you can just chat that to everybody. That's the directions we have. I'll keep an eye on monitoring that and try to raise those questions. In the meantime, as folks do that, just to highlight a few things that I think were really important and kind of a common thread throughout everybody's presentation. I think Dr. Shaw, you really made, I think, great points about the need to integrate this priority and the work necessary to address workplace violence with all of the other existing work that a clinical center does. I think one of the most important quotes from Dr. Muthing was that safety is very personal for everybody. I mean, I might get a tattoo with that on it. I think that's pretty inspirational and important. And then I think also the connection to Cincinnati Children's vision, that in order to achieve their vision, your vision, that you really have to address this and many other problems, but this included. And then Mary Beth, I think some pretty interesting statistics. You actually, for me, helped to underscore Dr. Muthing's point that the actual solution should not be considered a cost. The problem itself is a cost when you consider retention and all of the other issues that come along with it. So great presentation. I'm seeing some questions come in, so let's get to those. I know we had a few questions early on about length of stay. I think that you addressed those. You were all, as I understand it, referring to sort of multiple facilities. So I imagine length of stay is quite variable across the scope that you were covering. Anything that any of you would like to add about length of stay? That was one of the first questions that came in. pretty different across all of your organizations. So, okay. There's one question about what is the safety cross? I'm not sure, did that come up in someone's presentation? Would you like to address that, Dr. Shah?
It's a simple visual way to measure. So when you think of something that's really important that you want to make transparent on your ward, a safety cross is simply a calendar, and you put a green dot on it if you had a day where that incident didn't occur, or a red dot if it did occur. And it's just a really simple measurement system that allows everyone to own the issue.
Terrific. That sounds like a way maybe to back up Dr. Kingston's point about the simplicity that's often needed with reporting and other kind of feedback. So, okay, another question that I see in the chat relates to thoughts about de-escalation of intense behavior, in particular in outpatient centers where security may not be as robust. You may not have explicit personnel dedicated to security. Any thoughts about that in the outpatient setting and de-escalation?
Yeah, this is Mary Beth. I'll take a stab at that. We have a company that we use, and I don't know if you want us to name them or not. There's a lot of different modules. There's, very different approaches that you can have. But particularly in our outpatient settings and in our EDs, and certainly in our psych settings, we expand. We offer 4-hour de-escalation training. We offer, 1-hour quick updates. But for those areas, we have a 2 full day program, because we don't want to have people be security experts and focus on, a lot of physical pieces, but we do want to be able to educate people in those settings in how to keep themselves safe, so how to break a hold or something along those lines. So I think that's a really important piece, because in the ambulatory settings, we don't have the coverage of security personnel that you would have in an inpatient setting.
And I would just add in, Mary Beth, our system is, we have that same approach toward training and things, and it's just good to hear. I think all 3 of our organizations are taking a similar approach. I would want to just throw in this concept of predicting, that at first it feels like, what do you mean predicting, when it's going to happen? It isn't predictable. I think one of the things we've learned is it's more predictable than you would have thought. And the staff, and actually even the families, can help us. The families, particularly in pediatrics, they know what escalates their kids and gets us into situations. So sometimes that issue of predicting allows us to think about, what resources do I need today? Not always, that kind of thing. So,
if I could just chime in on that piece, I think, we've wrestled with I saw that Dr. Shah, you had the bro set. We've wrestled with kind of predictive scoring. We do have an alert that we use if someone has evidenced in our work setting aggression or actual physical violence. But I do think you're right. I think there's a whole big piece that we sometimes miss about appropriate care planning and identifying that, hey, someone has this history, or they have another issue, and they might be violent. We had that happen once when someone was coming out of surgery and they had a number of risk factors, and afterwards we said, were we surprised by this? And so I do think, for the patients as well, engaging behavioral health when needed and having appropriate care planning is really an important piece to preventing violence.
Okay, these are all great points. I saw a logistical question came up. Maybe we can just pause for that. Someone asked about a recording and whether that's going to be available. Patricia or Shubi, can you comment on that?
Yes, I'm just happy to comment on that as well. And Shubi, I'll stand corrected if I say anything off the grid here, but we will be making recordings available. The recordings are also available for people who could not register in time for the call to meet the capacity limits that we had today as well. So we're hoping that this will continue on in posterity and that it can be more widely shared across all of those who weren't able to join us for the live session today. Shubi, did I get that right?
That is completely correct, and an email will go out with more information on where to find that recording, as well as where to find the slides. So that was perfect, Patricia.
So thank you both. That seems particularly important considering the topic, and I think a theme across all presentations that it really does require kind of a team approach. And so I think maybe as an introduction for organizations, they might even consider this presentation just to sort of open up the topic. That might be what one of the participants had in mind with that question. Okay, I think you've all addressed training in part. Dr. Kingston, you raised some examples of training, I think de-escalation. Is there anything else that you'd like to add, any of the panelists, about training that you think is particularly helpful, maybe something that we may not be thinking about that's as obvious? What have you found is most important in terms of knowledge transfer training that folks could undertake?
And if I may, Jeff, I mean, we do train all of our staff in de-escalation techniques, restraint techniques, when they're working in these settings, but with the hope that they'll never have to use them. So, I would have said, 10 years ago, our approach to this sort of inpatient violence would have been quite punitive. We would have thought, how do we manage the violence? How do we make sure there are repercussions for those who are violent? How do we use punitive measures to make sure people know that what will happen if they become violent? Actually, what we want to do is go upstream. We want to leverage the knowledge that people have. Actually, if they just have a way to share in a safe place, the triggers, the subtle signs they've seen that someone is frustrated or starting to get irritated. And that's what I think we need to be able to create in our teams, is a way for us to have the shared purpose. We're working towards this issue that matters to all of us, impacts on all of us. And we're going to create spaces where we can, without judgment, share the things that we observe about people around us. And actually, we will see on a ward that there are subtle indicators leading up to an incident of aggression or violence. That actually, if we just had a space, and for us, huddles gave us that space where people could come together 3 times a day and just share their observations. I'm a bit worried about this person. He seems to be a little bit more agitated than normal. It could be because of this, it could be because of that. Share ideas with other people and take action to preempt something and turning into violence. So I think we've just learned about leveraging people's knowledge that already exists about the relationships they have with their patients and their behaviors, and be able to act in advance of something ending up as a violent incident.
I have one more thing to add, and that is we are finding that simulation helps us as well. So that might be something people want to build in, that we can do the training, but actually trying to put people in a situation where you're with someone who is escalating a little bit, and what do you do? That has been helpful, because our let's face it, our training is often you have it 1 year, and then in some instances it might be some time before you have it again. So I love Dr. Shah's idea of the huddles coming together and sharing that, but also having more frequent updates, sometimes via the use of simulation, I think is very helpful.
So it occurs to me, not just now, but as we think about this topic more, fear is such a prevalent aspect of the problem overall. And so I wanted to just introduce that as part of a question. There's a specific question about the role of a strong security presence and how that can help keep behaviors in check. Maybe that's also connected to this idea of prevention, which I really like, the concept that I'm hearing of being able to predict and prevent, particular examples. I wonder if sort of the use of a security presence in times when you think there might be, an event that's more likely to happen. Have you seen that as a strategy?
Let somebody else go.
Well, I'll just start with the kids, but Amar and Mary Beth, I know you have more experience than I do. Jeff, I would say in working with the kids, which again, this goes all the way up to 18 to 20 years old, but it depends. And I know that's not a satisfying answer, but there are definitely circumstances, and this is the kind of thing that we need to learn, we need to develop, we need to fine tune. There are some situations, some kids where that's exactly the right thing to do. And then there's others where that's the trigger, and it's exactly the wrong thing to do. So these are the kind of details that I think as we create learning environments, we're transparent, we're open about this, that we're all learning together, again, with the families and the patients and things, that like so much else we do in healthcare, we'll learn our way into a better way. But if we deny or hide or anything, we'll just keep trying what may or may not work. But Mary Beth, Amar, what do you think? And please feel free to disagree.
Oh, no, go ahead, Amar.
Just to add, I'm not sure that physical security necessarily creates safety. I mean, there are three types of security: physical security, procedural security, and relational security. And we do have physical security where we need to have fences, we have locked doors, we have all sorts of procedures where we need to manage risk. But we put far more emphasis on procedural and definitely on relational security. It's only by having an understanding of the impact on each other of our behaviors that we're really truly going to solve this as a community. And that's the place we want to get to.
Yeah, I would just add, I think the relationship and I'm speaking primarily in the acute care arena, the relationship between the security personnel and the clinical personnel is absolutely key. And it's not always, it hasn't always in some circumstances been positive, so that people should be trained together, understand their roles. I mean, we've had much more success with behavioral response teams where we say, instead of a show of security, we're saying this is a show of support, where people are trying to support the patient as opposed to, as you've said, Amar, that punitive approach. But I think that relationship is absolutely key in order to be able to successfully manage violence in the workplace.
Really great points. I hope this is helping the audience. It's definitely helping me sort of appreciate the important nuances of the topic. So there's a question about data. I think maybe I'll start with you, Mary Beth. I know you've done a lot with metrics and data. Can you add a little bit of information for us on that?
I think we still have a fair amount of work to do in that. You know, there's not really a consistent, and I'll speak again for the United States, there's not really a consistent measurement for looking at workplace violence. There's the OSHA reportables, but you know, I don't know if that really gets at what we want to look for. So to me, the data that has been most important is both as we're building this program and continuing to build it, there have been some process pieces. So we've looked at things, either best practice or things that have been demonstrated to work. Are they in place? So, you know, that's one data piece. So more of a leading indicator. And obviously we look at the number of events, but we also look at what's, you know, getting information from folks to see where things are happening and trending that data so that we can build an appropriate approach. One example is we've had incidents in parking garages, for example, and that's somewhere where we really needed to do some additional work on safety in those areas. So I think data can come from a number of places, but my primary focus has been on, does each site have the process in place that that we have demonstrated as best practice? And then are people reporting? And then what does that data look like coming back to us? And it needs to be monitored and reviewed. It can't just be data that sits somewhere as any data, isn't helpful if that happens.
Yeah, very important. Steve, anything to add about maybe the learning across organizations with the learning network and data and metrics in particular?
Yeah, I would totally agree with Mary Beth, is that the United States is still struggling with standardized definitions and how to share data, and that we should share data and things. But we've worked through some of that with the Children's Hospital, where we're sharing the DART data, the days away, restricted, transferred, and the OSHA recordable injury. It's helping us directionally, allowing us to get the kind of learning so far that I was talking about, that the organizations who are making the most progress are doing those things. We are not getting the kind of data that allows us to get to those finite learnings like we've done with patient safety, where we can create hack bundles. We're not that down into the data yet, and we need to get there. Otherwise, we're wasting time and there's too many people getting hurt.
Well,
Amar, I think you've made more progress in the UK on that. Yes, no? Or am I just hoping?
Some of the data, I mean, the data is not the most challenging part of this work, actually. We can create measures even where none exist. We're just now starting to do the similar kind of work on sexual violence in our inpatient settings. And there's much less documentation and reporting of it as an issue, but it doesn't mean you can't come up with some meaningful measures and start collecting it. I don't think that's the hardest bit. I think the hardest bit really is making people feel safe enough to start the conversation and feel like there's some hope that we can solve these problems.
I can't think of a better topic or a better phrase to end on. We're right at time. I'm seeing a lot of rich discussion in the chat. I think it's an ongoing conversation and definitely ongoing work. So with that, I'm going to thank our panelists and quickly turn things back over to Patricia. Thank you.
Great. Thank you so very much. Dr. Brady, thank you for your fabulous moderation as always. Thank you, Dr. Shaw, Muthing, and Kingston for your wonderful presentations today. And very importantly, for all that you're doing on the front end of this to help us get better and safer every day. I want to close with the spirit of Safer Together. It happens to be the name of the National Action Plan that was referenced several times, and it also came up, Steve, in your presentation, as well as through the threads and the messaging of all of our speakers today. You know, as we move forward with our collaboration and shared learning and the continuous spirit of improvement, it's so vital that we keep our heads and our hearts and our hands together as we ensure that we're driving toward safer experiences for patients and families, as well as the workforce who are providing such fabulous care. So thanks to all. Again, information about the recording will be available. And thank you for your questions and comments, which help us inform our future direction of virtual learning hours. Goodbye, everyone. Enjoy the rest of patient safety this week.